Anyhow, so we'll just it's thinking about it, I suppose. All right, so 6-week-old child has come with history of vomiting since 2 weeks, and there's no audio in this video.
Okay.
It's a very short video, but in the exam, it's not even this clear. So you have to be careful, okay? You should know what videos come in the exam. Okay?
Yes.
Okay. Okay.
Should I start?
Can we start?
Yeah. Okay.
Yes.
I can see a
Findings in the
6.
video.
Okay. I can see a 6-week-old baby girl in a home setting, not in respiratory distress, and I cannot see her face, but she is in nappies. I can see an circular to oval mass sliding from left upper quadrant of abdomen towards the center, and then towards the center and right side, and it is yes, and she is emaciated, but I would like to check her height and weight and plot on centile charts.
Okay, what is your history that you'll ask the mother?
History, in history, I will ask about the onset, course, duration, about the vomiting and type of vomiting, association, vomiting association with feed, and any history of pain, any family history, and any
Okay.
hospital admission with vomiting.
All right. Anything else?
Birth history.
What in the birth history specifically?
Was there, has she taken the drug history, and has she taken any antibiotics like erythromycin, the baby?
The risk factors you think of?
Yeah, the risk factor is
you have a lot of risk factors for this condition.
Yes, drug history, girls, family history.
Yes, family history, very good. What else?
I can just remember this.
How do you differentiate? You need to think about the differentials as well. Remember, before you go inside. Okay, what examination you do?
The examination, I will first do the general examination. Also check height, weight in OFC, and check for anemia, like general, complete general examination. Also, I will do the abdominal examination. And
in the abdominal examination, what are you going to do? Any bedside test?
In the abdominal examination, I will check the like with palpation. I will check for any other mass, and the size of the mass. It's like I will measure the mass.
Okay. And any other examination you'll do specifically
or any
other than
associated
abdomen?
anomalies. I will check the anal orifice. Like if there is anal
Okay,
atresia,
so
I will
we
check
can
the
like
spine.
child have any congenital abnormality? I mean, of
Yes.
that right now it's a 6 weeks old child, right?
Okay.
So, okay. What's your provisional diagnosis?
My provisional diagnosis is hypertrophic pyloric stenosis.
Any other differentials?
Can be duodenal atresia or intestinal obstruction, volvulus, or Hirschsprung disease.
Okay. Any others? Child has
Any muscular abnormality, abdominal muscle wall abnormality.
okay. All right. So if this is pyloric stenosis, how would you like to investigate?
For investigation, I would like to do arterial blood gases, serum electrolytes, and complete blood count,
What would
as she looks weak.
yeah, what is exactly the findings you see in the electrolytes and blood gases?
In electrolytes, I will see hyponatremic, hypokalemic, and hypochloremic, and in ABG's metabolic alkalosis. And
And how would you
I will
confirm
see
what is the diagnostic test?
ultrasound abdomen.
Okay, and what are the findings on ultrasound?
On ultrasound, the pylorus will be hypertrophied.
What are the dimensions?
I will check the dimensions, just for the dimensions of the pylorus. Its width, length,
Yeah.
and
Okay.
diameter.
What's the thickness and what is the length of the pile?
Thickness, normal is thickness
Normal
is
and pyloric
4
stenosis.
millimeter.
Okay.
Diameter is I forgot the diameter, and length is 10 millimeter.
Okay, all right. With this condition of hypokalemic, hypochloremic, metabolic alkalosis, what other possibilities can there be other than pyloric stenosis? Any other conditions?
Is Bartter syndrome, cystic fibrosis.
All right. So this is pyloric stenosis. How would you like to manage?
First of all, if there is the electrolyte, I will give the IV fluids and correct electrolyte imbalance and the alkalosis, and then refer to surgeon for surgery, and give
What's the
antiemetics
procedure?
for vomiting. It's pyloromyotomy ram. I don't know how to pronounce it, but Ramson.
Okay. Yeah. So what is the prognosis of this procedure? Time is over officially.
Okay, prognosis is good.
Okay.
Variable, but mostly it's good.
Any complications?
Complication, reoccurrence of stenosis, or it can be become loose. So
Okay.
there will be more regurgitation.
So if insufficient myotomy is done, then they might have recurrence of symptoms. Okay, let's go back to the video. So you need to comment on what you can see, and you can't see the face of the child. So say I cannot see, and I'd like to examine. In the eyes, you have to see, you have the fontanelle, all these things you should have mentioned, right? They have signs of dehydration.
Yes.
You have to correct the dehydration as well, not only electrolytes. So it's a well, is it a well-grown child? No, he's emaciated or she is emaciated. You can't speak on the gender unless it's written outside. And the child does seem to be dehydrated as well. You can see the skin, the abdomen is scaphoid, and the skin seems to be slightly, the turgor seems to be, the child is dehydrated. You can see the visible peristalsis from left towards right, and there's an olive straight mass. And the child is also tachypnic slightly. If you can see, the possibly even got, deep respiration. Maybe the child is so dehydrated, it's gone into metabolic acidosis even. I mean, we should not mention this part, but just say child appears to be tachypneic. History, you'll ask about the onset. Onset, it's 2 weeks back. So you can ask about how's any associated features like diarrhea. It could be acute gastroenteritis as well, isn't it? You have to rule out the basics, okay? It could be meningitis, so ask for fever. How is the feeding of the child? What's the relationship? Because it could be GERD, isn't it? Why aren't you asking about the post and feed vomiting? And this is the test I wanted you to do. Test
Feed
feed.
test. Okay.
Yeah. And after the vomiting, how's the child? What's the color of the vomit? Does he have any, the appetite is good, or is there any food aversion? Food aversion will be in case of GERD, and in case of pyloric stenosis, it's completely opposite. The child is very hungry, and immediately after vomiting, he want to feed. So this is very important how to differentiate a history of weight loss, and also the P for the dehydration assessment. How's the P? All right, and the risk factors, family history, is it a firstborn, is it a female child, and also any antibiotics in the recent past taken, like which antibiotics?
Erythromycin.
Yeah. So other than that, you can ask about the general activity of the child, any lethargy, abnormal movement. It could be meningitis or because of dehydration. Then examination, you have to start with the anthropometric measurements. It's less than 2 years, so don't say height. The length of the child, the weight, length, and OFC, vitals also, temperature, or full vitals. Why? Because the child may have, fever, might be dehydrated, so the tachycardia, tachypnea, everything has to be checked. Then capillary refill time, then the blood pressure, then your oxygen saturation because the child is tachypneic. Everything should be checked, isn't it? And also after abdominal examination, also check for his chest as well. If he's tachypneic, check, rule out any chest infection, and also check for the dehydration in the skin. Okay, anterior fontanelle, eyes, all these things. Okay. And then proceed to do the bedside test, which is the test feed, and this will also confirm. And you can also check for the gut sounds. Why didn't you check for gut sounds if you're having a differential of intestinal obstruction? You should check for the gut sounds, isn't it? So this is important. The provisional diagnosis is infantile hypertrophic pyloric stenosis, and other differentials you can give is that we mentioned. The intestinal obstruction due to volvulus, malnutrition, and also infectious causes like sepsis, UTI, meningitis. So rule them out. Then to confirm, you need to do the basic CBC. You can see for him concentration and also electrolytes and ABG. This will show hypokalemic, hypochloremic, metabolic alkalosis, and the differential diagnosis we have to know. Okay. So then confirmation is by ultrasound. You have to see the dimensions. So remember the pi 3.14. Remember from mathematics. So if the child has a thickness more than 3 and the length more than 15 to 17, so this means the child has pyloric stenosis. They're asking the dimensions in the exam. Okay, so this is why I'm asking you. So other than that, you can, if you have time, you can mention I'd like to rule out all the other differentials, but mainly for pyloric stenosis, this is enough. Then the management is the Ramstead procedure, but before that, you have to say, I'd like to admit the child, correct the fluid and electrolytes, because if you don't, then they will have complications, and we must correct the electrolytes, hypokalemia especially, before you do the procedure. It's a very, not a high risk procedure, good prognosis. However, there might be recurrence of symptoms if there's not enough insufficient pylori to be done. So there might be recurrence of symptoms. Otherwise, pretty good prognosis. Okay. That clear?
Yes. Thank you.
Okay. I'm gonna give you the feedback. Let me stop the recording first.